Assalamualaikum warahmatullahi wabarakatuh. Good morning. I am Andren Fajar Kusumadewi, psychiatrist from Department of Psychiatry, FKKMK UGM. In this opportunity, I would like to deliver the lecture of sexual disorders and sexual orientation. The learning objective is to understand definition, classification, pathophysiology, diagnostic, management strategy, and treatment pharmacological and non-pharmacological of sexual disorders in desire, arousal, orgasm, sexual pain, sexual dysfunction, sexual disorder related to medical condition, and substance-induced sexual disorder, and to understand the sexual orientation. For the introduction, sexuality is affected by anatomy, physiology, the culture in which a person lives, relationship with others, and developmental experiences. Normal sexual behavior brings pleasure to oneself and one partner, and involving stimulation of primary sex organ and devoid of inappropriate feeling or guilt or anxiety, and is not compulsive. The sexual function is for reproduction, expression, communication, and recreation. This is sexual responses cycle. The first is desire phase, or in Indonesia we call it hasrat, and then arousal or excitement, and in Indonesia we call it rangsangan or bangkitan, and then orgasm phase, and the last is resolution phase. There are many factors that affect physiological sexual responses. For example, psychosexual development, psychological attitude toward sexuality, and also attitude toward one's sexual partner. Masters and Johnson description of the phases of sexual response cycle. There are desire phase, sexual fantasy that precedes the physiological responses, particularly in men. And the second is excitement or arousal phase. It is 30 seconds to 3 minutes. It includes penile erection, tightening scrotum, secreted mucoid fluid in copper glands, nipple erection, clitoris enlargement, congestion of labia, mucoid secretion of Bartholin gland. The excitement phase is the stage that human sexual response cycle which occurs as a result of physical or mental erotic stimuli, such as kissing, making out, or viewing erotic image that leads to sexual arousal. In males, the beginning of excitement phase is observed when the penis becomes partially or fully erect, often after only a few seconds of erotic stimulation. In female, the excitement phase can last for several minutes to several hours. The onset of vasocongestion results in swelling of the woman's clitoris, labia minora, and vagina. The orgasm phase, it's occurred 3 until 15 seconds, ejaculation, increase of vital sign, loss of voluntary muscular control, rhythmical contraction of sphincter, contraction lower vagina at interval 0.8 second, and flush of the skin. And the end, resolution phase, it occurs 10 until 15 minutes, and the sign is flush disappearance, refractory period, return to baseline state, and decrease to normal size. In Diagnostic Statistical Manual for the Revised or DSM-4-TR, sexual dysfunction defined as a disturbance in the sexual response cycle or inability to respond to sexual stimulation or the experience of pain during the sexual act. First, we discussed sexual desire disorder. Desire disorder is a persistent absence of desire for sexual activity. There are two types. The first, hypoactive sexual desire disorder, and the second, sexual aversion disorder. Sign and symptom of sexual desire disorder is decrease in frequency of sexual activities, complain other sexual disorder like erectile dysfunction, depressed, irritable, and not have sexual desire although seeing attractive partner. The etiology of sexual desire disorder is physical factors like hormonal alteration, renal disease, cardiac disease, etc. And also psychogenic factors like boredom with partner, guilt, stress, and sexual trauma such as rape. There are two treatments, is causative and sexual therapy. Men who has hypoactive sexual desire disorder have never experienced many spontaneous erotic or sexual thoughts. Reported incidence is 2 until 6%, usually because fear about sex. Lack of desire can also result from chronic stress, anxiety, or depression. Abstinence from sex for a prolonged period sometimes results suppression of sexual impulses. Loss of desire also be an expression of hostility to a partner. Sexual arousal disorder. Criteria for sexual interest or arousal disorder is diminished, absent, or reduced frequency of at least 3 of the following for 6 months or more. The first is interest in sexual activity, sexual or erotic thought or fantasies, initiation of sexual activity, and responsiveness to partner's attempt to initiate, sexual excitement or pleasure during most sexual encounters, sexual interest or arousal elicited by any internal or external erotic cues, and genital or non-genital sensation during most sexual encounters. Etiology also divided into physical and psychogenic. The physical, like disorder which inhibit vaginal lubrication, like diabetes mellitus, lack of estrogen and vaginitis, and also drugs and also smoking. The psychogenic etiology is sexual trauma. Hormonal pattern may contribute to responsiveness in women who have arousal disorder. Alteration in testosterone, estrogen, prolactin, and thyroxine levels have been implicated in this disorder. Medication like antihistamine and anticholinergic can decrease in vaginal lubrication. We must evaluate factors such as life stresses, aging, menopause, adequate sexual stimulation, general health, and regimen before making diagnosis. The etiology usually relationship problem and marital discord. Sign and symptom of sexual arousal disorder is lack of vaginal lubrication, clitoris failure to erect, lack of arousal feeling, and erectile dysfunction. Male erectile disorders. A man with lifelong male erectile disorder has never been able to obtain an erection sufficient for vaginal insertion. It's reported 10% until 20% in young adult population. It can be organic or psychological cause or combination both. 20 until 50% have organic basis condition. Medical condition implicated erectile disorders is like infection, cardiovascular, renal disease, endocrine, neurological, and also pharmacological and substance. The pharmacological agents that implicated erectile disorders is like TCA or tricyclic antidepressant like amitriptyline, trazodone, lithium, antipsychotic, chlordiazepoxide, antihypertensive, digoxin, etc. And for the example of substance is alcohol, barbiturate, cannabis, cocaine, heroin, methadone, and also morphine. Definition of erectile dysfunction is inability to reaching or keeping penis to erect adequately to have sexual activity. It's classified into two groups. The first is primary erectile dysfunction that cannot erect from beginning, and also the secondary erectile dysfunction is successfully erect before. Psychogenic erectile dysfunction etiology. It is divided into two factors, is predisposing factors and precipitating factors. The predisposing factors, the first is negative side for sex, sexual trauma, lack of family relationship, poor lifestyle, and also personality factor. The precipitating factors is like physical disorder, degenerative process, poor honesty with partner, lack of communication, excessive fear, and lack of sexual education. The hormonal etiology of erectile dysfunctions is prolactin and also tyrosine. The neurological etiology is parasympathetic disorder and brain disorder. And also the blood vessel etiology is sclerosing the artery and also vena. And the drugs is psychotropic agent, antidepressant, antihypertensive, hormonal treatment, anticholinergic, and recreational drugs. And also surgery etiology, for example, brain surgery, vertebra, and pennilectomy. Examination for erectile dysfunction is like the questionnaire, International Index of Erectile Function, and also physical examination, audiovisual test, nocturnal penile tumescence and rigidity or NPTR, and also laboratorium tests like CBC, blood glucose, cholesterol, lipid, liver function, hormone, and renal function test. First line is sex therapy and oral erectogenic agent like yohimbine, apomorphine, trazodone, and also sildenafil sulfate. And the second line is injecting vasoactive substance to corpus cavernosum like papaverine, phentolamine, prostaglandin, etc. And the third line is prosthetic device implanted in the corpus cavernosum. It is semi-rigid and inflatable. Orgasmic disorders. Orgasmic disorders consist of female orgasmic disorders and ejaculation problems in male. Proposed DSM-5 criteria for female orgasmic disorders. On most occasions of sexual activity for at least 6 months, there are marked delay in frequency or absence of orgasm, and markedly reduced intensity of orgasmic sensation, cause marked distress and interpersonal problems, not due to medical illness, another physiological disorder, or the effect of drugs. The criteria of female orgasmic disorder is recurrent or persistent inhibition or absence of female orgasm after normal sexual excitement. Numerous physiological factors associated with these disorders, for example, fear of impregnation, rejection by a sex partner, damage to the vagina, hostility toward men, poor body image, feeling guilt about sexual impulses, and also cultural expectation and social restrictions on women. Non-orgasmic women may complain frustration in many ways. For example, pelvic complaints, lower abdominal pain, itching, vaginal discharge, increased tension, irritability, and fatigue. Etiology of female orgasmic disorder. There are psychogenic like rigid background, sexual trauma, incest, boring, anxiety, lack of honesty to the partner, lack of communication, lack of sexual arousal, ineffective coital position, and sexual dysfunction to the male. And the treatment for female orgasmic disorder is causative treatment, sexual therapy, and masturbation program. Orgasmic disorder that affect male, the first is premature ejaculation. Early or premature ejaculation disorder criteria is ejaculation that occurs too quickly and it is persistent or recurrent before they wish to, usually before 1 minute after penetration. More commonly reported among college-educated men than less educated men. It can be related to the concern for partner satisfaction. The incidence is 35 until 40% of sexual dysfunction cases. After ejaculation, we found difficulty in ejaculatory control usually associated with anxiety, recurring sexual act, unconscious fears about vagina or vagina dentata, for example, negative cultural conditioning, and stressful marriage. Men whose early sexual contact with prostitutes might have been conditioned to achieve orgasm rapidly, and the treatment is sex therapy and drugs that can control ejaculation. One of orgasmic disorder in male is delayed ejaculation. Delayed ejaculation is defined of inability to reach ejaculation in the vagina. The etiology also physical and psychogenic like genital disorder, impaired sympathetic ganglion, and guanethidine. And also for the psychogenic is negative side about sex, and the treatment is sex therapy. One of delayed ejaculation is persistent difficulty ejaculating, or men achieve ejaculation with a great difficulty. The incidence is lower than early ejaculation disorder. And etiology, increased use of antidepressant, high use of internet pornography, rigid and puritanical background that perceives sex as sinful and genital is dirty, interpersonal difficulties, obsessive compulsive disorder, hostility toward women. Orgasm Phase disorder. It consists of postcoital dysphoria or post-sex blues and postcoital headache. Postcoital dysphoria is extreme dysphoria or sadness after coitus, and postcoital headaches characterized by headaches immediately after coitus may last for several hours, usually localized in occipital or frontal area. The cause is unknown, may be caused by vascular, muscle contraction, or psychogenic. Sexual pain disorder. The first is dyspareunia. Dyspareunia is defined of persistent or recurrent genital pain before, during, or after intercourse. Pain in the genital organ due to sexual activity. 50% prevalence rates. The etiology can be medical cause like infection, lack of vaginal lubrication, or menopausal problem. And for the psychogenic or dynamic factor is history of rape or abuse and anxiety about sex act. This is the etiology of sexual pain disorder: genital inflammation, IUD, condom, lack of vaginal lubrication, and the treatment is sexual counseling and drugs. Vaginismus. Vaginismus is a sexual dysfunction which manifests as abnormal spasm of the vaginal smooth muscle. It is recurrent or persistent involuntary spasm of the musculature of the outer third of vagina that interferes with sexual intercourse. It prevents the introduction of the penis into the vagina. This can occur during gynecological examination, during introduction of finger or speculum. A sexual trauma such as rape may cause vaginismus. Physical etiology is like hymen disorder, infection around vagina, and also impaired hymen cause of delivering baby. And also the psychogenic etiology is rigid background, sexual trauma, coital pain, fear to pregnant, and also fear to sexual transmitted disease. And the treatment is in-depth counseling and assisted dilation. Discuss treatment for sexual dysfunction. Before 1970, the most common treatment of sexual dysfunction was individual psychotherapy. It used basic concept of classic psychodynamic theory that assumes sexual inadequacy has root in early developmental conflicts, specifically in psychosexual stage of Freud development theory. It focuses on the exploration of unconscious conflict, motivation, fantasy, and various interpersonal difficulties. 1970, Master and Johnson developed dual sex therapy. It based on concept that the couple must be treated when a dysfunctional person is in a relationship. Both must participating in therapy program to cope with disharmony or misunderstanding in relationship. Other non-pharmacological therapy, for example, hypnotherapy, behavior therapy, mindfulness, group therapy, and analytically oriented sex therapy. Biological therapy including pharmacotherapy, surgery, and mechanical devices. For sexual dysfunction, for example, phosphodiesterase inhibitor like sildenafil or Viagra, nitric oxide enhancer, also tadalafil, vardenafil that can use to erectile dysfunction and increase lubrication in women. Drug preparation, there are tablet, injection, transurethral, and cream. The common side effect is facial flushing, headache, dyspepsia, and also rhinitis and transient visual disturbances. Also, we can use anti-anxiety agents, may have some application in tense patients, although it also can interfere with sexual responses. Dopaminergic agent can use to increase libido. Example, paroxetine 20 until 40 milligrams daily, clomipramine 10 until 50 milligrams daily, sertraline, and also fluoxetine. It is the treatment for premature ejaculation. The treatment for sexual dysfunction also hormonal therapy. Androgen increase the sex drive in men and women with low concentration of testosterone. In prolonged use, it can produce hypertension and prostatic enlargement in men and virilizing effect and deepening voice of women. Estrogen delivered locally formed in vaginal rings, cream, and tablet can be used for women with arousal dysfunction. Estrogen, progesterone are anti-androgen to treat compulsive sexual behavior, usually in sexual offender. This is the mechanical therapy, like vacuum pump or mechanical devices for patients without vascular disease to obtain erection. And the surgical therapy is male prosthesis, semi-rigid prosthesis that produce a permanent erection that can be positioned close to the body for concealment. And also an implantable type that is implanted with its own reservoir and pump for inflation and deflation. And also vascular surgery is bypass surgery for penile artery for vascular insufficiency due to atherosclerosis. The second topic is sexual orientation. Sexual orientation is defined as one's attraction, desire, and arousal toward others based on their sex and gender. Sexual orientation is persistent emotional attraction and sexual behavior. Types of sexual orientation is heterosexual, attraction to the opposite sex, homosexual, attraction to the same sex, bisexual, attraction to both sexes, and asexual, lack of complete absence of sexual attraction. In 1973, homosexuality was eliminated as a diagnostic category by the American Psychiatric Association or APA, and in 1980 it was removed from Diagnostic and Statistical Manual of Mental Disorders. The ICD-10 states that sexual orientation alone is not to be regarded as a disorder, so having sexual orientation other than heterosexuality is no longer considered as pathological. A psychological theory that affect the sexual orientation. The first is Freud theory. homosexuality as an arrest of psychosexual development, and mentioned castration fears and fears of maternal engulfment in the pre-Oedipal phase of psychosexual development. And the biological factor is gen XQ28 in gay males, and also genetic study have shown higher incidence homosexual among monozygotic twin than dizygotic twins. Homosexuality is not considered as disorder. We must note many problems that can be occurred in a patient with homosexuality. The first is suicidal ideation or suicide, abuse, discrimination, alienation, guilty, worried, feeling different, and also substance use. So, can homosexuality be cured? There has been no report or research that sexual orientation can be altered. Conversion therapy or attempt to alter sexual orientation, especially with force, is deemed unethical. Medical help focus on management of distress caused by the internal conflict that patients experience, not their sexual orientation. So I think it is the end of this lecture. Thank you very much for your attention, and also it is the reference for our lecture. Thank you very much.